Thanks very much. It's good to be here. I'll just offer some brief remarks and try to raise some issues around the supportive housing service system and how it might respond to all these exciting opportunities, transformational opportunities presented by this much more integrated approach to health planning and service delivery that Jason outlined and Bruce talked about as well. I mean, clearly a focus on housing in a Medicaid clinical context it's a laudable attention to the social determinants of health and recovery, and that's that process of convincing others that investments in social issues and social strategies can have impact on health as well. Conversely, I think it's incumbent upon those in the social and recovery systems to think about clinical and health issues as well. These work both ways. If we were making the argument that there's an impact from one on the other, we should be thinking about how to integrate those together, not only in terms of service delivery, but in how we measure success, how we monitor outcomes in the social service sector. An example here in the city at the health department's supportive housing programs that we oversee in Hopwa for people living with HIV, we've tried to integrate attention to engagement in clinical services, receipt of HIV viral load testing into the expectations and the general practice of supportive housing providers. How might we think about similar approaches and perspectives in supportive housing for people with mental illnesses and substance use disorders? There's a lot of this going on now. How do we institutionalize it and think about it more systematically? We know that treatment engagement is a critical factor in recovery at avoiding costly and undesirable outcomes such as ED and hospitalizations, ED use and hospitalizations, transitions from hospitalization, another important metric that we might consider thinking about in terms of supportive housing expectations and outcomes, and attention to physical health matters, tobacco use, diabetes management, hepatitis C screening, all these things. How do we build these sort of shared metrics of accountability across these different systems, and then think about the service models to achieve them? And then, of course, it's not only about clinical outcomes. We need to continue to emphasize those recovery-oriented social outcomes that are equally, if not more important, than in these settings. We've started at the department thinking about employment in supportive housing and how to measure that and what expectations and supports to give to providers around employment. This is, of course, a strong interest of our colleagues at HRA as well. We began asking supportive housing providers to report, to collect information on employment status of their tenants, clients in supportive housing. We know the rates are incredibly low across the board for employment around for people with serious mental illnesses. Not surprisingly, we found rates of 10, 11% among people living in supportive housing. So there's a lot of barriers and a lot of issues around employment to think about, interactions with benefits and availability of jobs clearly, and what skills providers have. But these are the kind of increased focus on outcomes and metrics and new ways of thinking about the goals of supportive housing. And similarly, as we think about this integration of Medicaid and health issues, we have to balance those with the other important outcomes that supportive housing will have impact on, even from a cost perspective, whether that's shelter or jail or other not easily monetized health and recovery outcomes. A word about high users. I think that's something that we need to talk about, the challenges and adaptations to service that need to come with a more focused attention on a so-called high user population. Clearly built into the ways that populations come into supportive housing, extended homelessness, serious illnesses of a variety of sorts. There's an expectation that addressing these issues is a complex and challenging one. But in speaking to many of you, many providers, it's clear that service models expectations need potentially to change, and I think that's something that would be important to talk about. And perhaps just as challenging is those for whom utilization is not high now, but who are at risk for becoming higher need in the future. It's not always easy to predict who, using past experience, who might need increased services down the road. So that's more of a prevention perspective. But again, how do we think about the service models in supportive housing to address that? A word about information systems and electronic data. I think with these new shared expectations around clinical and recovery outcomes, we need to be thinking about sharing information more between a variety of service providers and with clients themselves, for that matter. We need to think about the right way to include the variety of providers, clinical and non-clinical, in the exchange of information. I think the development of health homes with the diverse network partners and the emphasis on electronic data exchange is an impetus in this direction. We need to think about what data is collected, at what level, how is it shared, what the systems are that need to be developed, how a shared plan of care is both developed and then contributed to by different partners in care. Confidentiality and consent issues, all those things is another important issue. So in sum, expectations, in this sort of transformation, expectations are changing to some degree around who is being served, potentially the goals of service, what collaborations and tools of collaboration should be, and how we measure success. And I think that's some topics of conversation that I'd be very interested to hear from you on that. So thank you very much.